Hiya. Welcome to this morning's session, which is titled A Modern Way of Letting Go, Decommissioning Against a Tide of Adoption. We're going to explore the complex, contentious and understudied world of decommissioning, de-implementation and de-adoption, something that is so complex as a concept that it's got 3 names and no names at all. It's a very complicated area to try and look at. It's broadly stopping something or doing less of something that is not working as intended or we're doing too much of. I'm Johnny Clark. I'm a Senior Policy Fellow at the Health Foundation, and I'm lucky enough to be joined by an esteemed panel, some of which are with us in the room and some of which are joining online. And what I'd like to do first is ask them to introduce themselves. So, starting perhaps with Sally to my left.
Hi there, I'm Sally Gainsbury. I'm Senior Policy Analyst at the Nuffield Trust, where I focus on funding and finance, and I've also got a big interest in equity.
Arno.
Hi everyone, I'm Arno Wolters. I'm Head of Improvement Analytics at Cumbria, Northumberland, Tyne and Ware NHS Foundation Trust, which is a mental health trust that provides services across the north of England. And I'm also the implementation and knowledge mobilisation lead for the NIHR Applied Research Collaboration across the northeast and North Cumbria.
And Leila.
Hi everyone, thank you for accommodating us online. I'm Leila Regenos from the University of Bristol, and I'm a Professor of Social Medicine and Health Policy.
Right, thank you. So I thought it might be useful to introduce the reason why we decided to have this session today. And when we were planning the conference, I was sort of reflecting back on my experience as a clinician and as an evaluator over a long time, and how much time I've spent looking at new things starting and how little time I've spent looking at old things stopping. And whether that's new technologies or clinical pathways, it feels like the gravity sort of drawing us towards the shiny new thing rather than the thing that's already in place. And reading the 10-year health plan last year when it came out, I've pulled some quotes, but it is not short of optimism and excitement when it comes to how innovation and adoption of new things can fix the NHS. So there's a whole section saying we will remove bureaucracy and barriers to adoption and spread. Once an innovation has been robustly assessed by one NHS organisation, further NHS organisations will not be able to insist on repeated assessments. And we'll also introduce a new mechanism for a presumption of adoption for innovations that can demonstrate a step change improvement in quality. And I'll ask you as evaluators to sort of cast aside your scepticism about the notion that an innovation that works in one place can work equally well in another. But there's also language in there about how commissioners might be directly judged on how well they adopt innovation. So we've got a quote here: adoption of innovation will be a criterion for how providers and commissioners are judged under a new regime of earned autonomy. So the 10-year plan is very loud on adoption of new things, but it is much quieter on decommissioning. So the only references to decommissioning are to stopping providers that are providing poor quality care from being able to do so. Far less on how we go about accommodating the adoption of new things alongside stopping things that we no longer need. And in the context of that, there's a real risk that with this pressure to adopt, we end up with a layering of new things on top of each other without taking away the things that aren't working or are no longer needed. And we thought it would be very useful to have a session about that. And some of the examples of how this could happen are really simple, small things, like, for example, getting a letter as well as a text message, as well as a notification in the NHS app about an appointment that you have at a hospital. But it can extend all the way to far bigger and perhaps more problematic things, like, for example, having 2 clinical services, one that's an old one that's a new one, that are potentially overlapping or are not so clearly distinct that patients and clinicians know what the right way forwards is and which service is the one for them. And I think there's also similar asymmetries in how evaluation is positioned in relation to adoption and de-adoption of different pathways. So funding and excitement and general ambition are pulled towards new stuff rather than old stuff. It's far easier to find funding opportunities to evaluate the adoption of a new thing rather than something stopping. And so I thought it would be very useful to think about in this session the more general perspectives about our experiences of existing as evaluators and as commissioners and academics in the context of new innovations, but also about stopping things, but thinking about the role that rapid evaluation can play in understanding decommissioning, whether it has a role, what the scale of that role is, and how it's been applied in practice. And with that, recognising that it's potentially quite a sensitive topic, one of the things that we tried to do today was to get perspectives from commissioners on this stage, and that was something that we didn't really manage to do in quite the way that we'd intended to do, but by virtue of a man that wears many hats and is also very willing to help. We've got the contribution of Arna Walters first, who has already introduced himself, but I think it'd be good to hear a bit more about your experience, both as an evaluator and as someone working in a commissioning organisation.
So I guess just to clarify, I work in an NHS provider rather than a commissioning organisation. But yeah, I've been working with Johnny to try and shape this, and we reached out, not for want of trying, to quite a lot of different commissioners, and even initiatives where we thought there was quite some positive associations around sort of stopping services. But unsurprisingly, there isn't a whole lot of interest to talk about stopping things. So I will put on my NHS hat today and I guess give you my perspective, and then hopefully we can explore together what the role is of evaluators in all of this. I think most people will be familiar with sort of the mental health system across England. Obviously we're funded through NHS England, like most other trusts, and during the pandemic the demand for mental health services very substantially increased. So in the hundreds of millions of pounds were made available for additional mental health services across the country. This funding was temporary, and we've sort of now reached the cliff edge where that funding has stopped. Over the past year, we've had to reduce our staffing levels by about sort of 10%. So that's about losing 900 frontline staff in delivering the services that we do. So then the question is, how do you decide what to scale down and where to reduce the services you're offering? And it's really difficult to think about sort of the role that evaluation might play in this. I think in particular, you might think, let's evaluate the changes of when the additional money came in and try and understand the impact that is having, and maybe that can help us guide in what we can scale down again. But I think what has happened in the meantime is that the need in the system has completely changed. And the patients that come through our door now are not the patients that came through our door in 2019. So that's not really a strategy that we can adopt. So I think in practice what has been happening across most mental health providers is the typical sort of cheese slicer method, where you just do a little bit less of everything in the hope that your numbers start adding up at some point. But I think as a result we have some services that have immensely long waiting lists, and I think the sort of the lack of people being surprised at the size of some of these waiting lists is almost the most shocking thing. So I was in a meeting recently with a mental health trust where their waiting list for ADHD assessment for adults has grown to 15 years. And most people in the room not batting an eyelid at that number. But that essentially means you're not providing that as a service anymore. I think in our trust there's like 2 people doing these assessments, and we cover a population of over 2 million people. So you can sort of see why at some point we need to be more decisive in sort of, what are the services we want to provide, where do we want to stop? Because sort of continually reducing them, that doesn't really work. And I think there's another context, and Johnny hinted at that. So we are one of the 6 pilot sites that has a 24/7 community mental health hub that opened earlier this year, which should provide a new way of accessing mental health services, should avoid having to get referrals from your primary care, your GP. You should be able to just come directly to us. And this is a whole new pathway that's already sort of attracting patients that we have never engaged with before, which is obviously really good in terms of meeting those unmet needs. But we also have a lot of patients that have previously engaged with us coming through those new pathways. So there comes a point where we then need to decide what are the old pathways that we can scale down or shut down altogether as we make that shift to sort of more community-focused services. And I don't really have the answers, and I'm hoping we'll explore some of that today, but I think understanding how we can use data and evaluation in making those decisions, I think, is a really important challenge.
Thank you. Did you have anything else?
No, I'll stop there.
No. So, I mean, one of the things that you were talking about there was about the way that you can, with your local knowledge of a context that you're operating in, you can understand what's best to stop and how best to go about doing it. Do you think local organisations are best placed to be making those decommissioning decisions?
Yeah, I think so. Because the sort of the need in the population is going to be very different, and in different parts of the country. I think the even within our patch, we cover essentially the entire north of the country. So we've got services out in the Lake District where we just opened this new hub, but we also serve Newcastle, Sunderland, up to the Scottish border in Berwick, and the need in the population is very, very different in each of those areas, and I think it's very difficult to sort of centrally understand where to go and how to go about that. I also think that sort of the sheer sort of geographical size of some of the footprints of providers also means that even centralizing services within our own catchment area is very difficult. If you are on the West Coast, your nearest mental health inpatient ward will be in Carlisle, which is about an hour and 20 minutes away. And if those beds are full, you'll be sent to Newcastle, which is essentially at the other end of the country.
Yeah. And I know that you use data a lot in your work in your analytics function. What role does the local data infrastructure that you have within your patch allow you to understand the potential impacts or the real impacts of any service changes that you've seen in the area?
I think this is where data integration, and it will surprise nobody in this room, is really, really important. So if you think about the data we have access to as a trust, that's a really small part of sort of a patient pathway, particularly in mental health services. So when patients, so when people develop a mental health need and they go to the primary care, to their GP practice, like to some extent that need will be met within that system, then there comes a point where the GP wants to escalate to secondary care. So that'll be the first point of contact they have with our service. But if people don't meet the bar at that point for us to provide our services, we might have to reject that referral, and then we have no idea what happens to those patients. So we also have no idea what happens with the outcomes of those patients as a result of our decision making if we just look at our data in isolation. So we are lucky to have a secure data environment in the Northeast that is now up and running and flowing data from quite a lot of providers, both acute mental health and primary care. So we're getting to a point where it might be able to start looking at these sort of patient pathways from the start to the end. So NICE guidelines, particularly around mental health, have been updated and very often now cover the entire pathway, which means it's very difficult for us to understand whether we are following the NICE guidance in the care we provide if we don't have sight of that bigger picture.
Thank you. And one of the things that we were thinking about when developing the session was that often decommissioning decisions or de-implementation decisions, they're often contentious. They're often things that are not politically neutral acts. And I think what I'd like to maybe hear from you, Sally, is from some of your experiences of working in, I know, some local contexts where you've been involved in decommissioning decisions and thinking about the political context in which that exists. So I think you've got some good experience you can potentially talk about now.
Yeah, thank you. So we've done some work over the last 5 years, I think, with the GLA, so the Greater London Authority, Mayor of London, and also most recently with a council up in the Midlands, scrutinising local, in the case of London, 3 major acute reconfigurations. I'm going to try and avoid saying which configurations they are, but they might come up. It's all in the public domain, you can find it on our website, but just help me sort of speak slightly more openly about it. And then in the case of the recent work for a council in the Midlands, I was looking at an ICB's £300 million savings programme. So these are not just in and of themselves decommissioning programmes. They are, in the case of the reconfigurations, there were 2 elective orthopaedic reconfigurations. These are generally centralising elective orthopaedics along the principles of the GERFT programme. So there was the intended outcome was to improve the efficiency but also the effectiveness of elective orthopaedics. One of them was a maternity reconfiguration that was, I think it's fair to say, was mainly based on addressing staff shortages. So generally staff were spread too thinly across the patch as they were, and so they were going to, the proposal was to close down one maternity and neonatal unit, and the decision that had to be made was which one was going to be closed down and which one was going to be expanded to absorb the service. the essential sort of question for the politicians, and we're talking about local politicians here, so perhaps slightly less sort of party political, was essentially the grubby business of who gets what. So who is going to be losing out in this reconfiguration generally. And I think one of the really interesting and problematic ways in which that's answered is the what in this case isn't actually health. It's not even healthcare outcomes, it's access. So very quickly, the conversation and debate reduces down to who is going to suffer a deterioration in healthcare access, rather than what is the ultimate outcome, or is that access even going to result in a deterioration in outcomes and a deterioration in outcome equities, or it might be the opposite. It might result in an improvement in outcome inequities or reduction in outcome inequities. And of course, there's a very obvious reason for that, which is that the relationship between healthcare access and healthcare outcomes and health is very hard to pinpoint, and remains a sort of a big challenge for our line of work. But in addition to that, I think, or perhaps partly stemming from kind of the sort of nebulous connection between sort of healthcare access and health outcomes, is, I think, a real lack of clarity around what the NHS or healthcare is actually for. And I know that is quite navel-gazing, but I think this very quickly comes to the fore in these kind of small p politics conversations around reconfiguration. So is the healthcare system there to maximise population health? I mean, a lot of us might wish that was the case. If the NHS existed to maximise population health, it would be a lot more focused on primary care and maternity care than, we wouldn't have hemorrhaged 1,000 GPs in the last decade, and women wouldn't be voting with their feet to avoid maternity units, which is sadly the case at the moment. Is it to minimise risk? I mean, often in conversations we talk about minimising risks of harm. Is that immediate harm, or is that future harm? Is that population harm, or is it harm to the identifiable patient in front of us now? Is it to maximise capacity to benefit? That's something health economists like to talk about, maximising capacity to benefit. But the reality is that very few people actually have their capacity to benefit maximised, and the threshold for deciding when we cut off whether or not we're going to continue trying to maximise this individual patient's benefit does differ, and most obviously it differs depending on whether or not the capacity to benefit is to come through a new drug recently authorised or recommended by NICE, or is it through some other form of intervention. So there's a lack, there's both a lack of willingness to discuss how that stuff is rationed, but one of the reasons we don't even have a framework really for discussing that, because we don't have a useful framework for talking through these kind of competing ideas of what healthcare is even there for. So as a result of that, instead, these reconfigurations or decommissioning decisions focus on the question of access. And in our experience in the work we've done in these major reconfigurations in London, and also in the £300 million spending reduction plan, or mainly spending reduction plan for the ICB, the framework for assessing these is the Equality Act, and the 2010 Equality Act, but which is not designed for assessing whether or not we're doing we're doing the best we can from a healthcare system, but it's very familiar. There's a strong body of case law around it. Very interestingly, of course, none of that case law relates to deprivation, because deprivation is not a protected characteristic under the Equality Act. When it is there in the Equality Act, it's Section 1 of the Equality Act, is a method for dealing with deprivation. It wasn't implemented by the coalition government that effectively implemented the Equality Act of 2010. I'm probably going slightly over time, aren't I? Am I all right? I'm okay?
Rush,
right, okay, right. So instead what we find in the reconfigurations is a focus on access, very little consideration of how access needs might differ between population groups, between those protected characteristic groups. Often, to be fair, socioeconomic deprivation is thrown in as an addition. The NHS is fully cognizant that economic deprivation is a big driver of health inequalities, but the service doesn't have the tools or people leading the reconfigurations. By the time you get to reconfiguration, the tools aren't there to do this kind of differential sort of needs assessment. So instead you have quite a rudimentary assessment of changes in access and a lot of consideration of changes in travel time and travel distance rather than one health outcome. And this means that some really important questions about, about healthcare outcomes are overlooked. So, and even narrow questions relating to the service that is being changed. So, for the elective orthopaedic centres, for example, one of the big unanswered questions, although someone here might know the answer now, because I know there is research going on into this question around what do standalone elective surgery centres mean for the roughly 30% of patients who need to be treated in facilities with HDUs. I know there is some research going on around that, but that hasn't, so far in the reconfigurations that have implemented these things, that has not been taken into consideration. If there is an interest in achieving equity for elective orthopaedic patients, what are healthcare systems going to do about those patients who still have to effectively battle it out in co-located theatres with the emergency patients coming in. And another regretful result of this situation is we find actually potentially quite wasteful and counterproductive mitigations, because if the biggest concern is to avoid a reduction in access for any given group, and by the way, the Equalities Act doesn't offer you any sort of framework for measuring, for prioritising for prioritising the most egregious forms of access inequalities. So instead we have a sort of counterproductive mitigation. So in one case we had a proposal for a universal £80 travel budget that would be, anyone who was going to suffer a deterioration in travel times could access this budget. In terms of healthcare system that has limited resources, are we getting our most healthcare bang for the buck if that is the mitigation? And then very interestingly, in the maternity reconfiguration we looked at, one of the biggest problems with the maternity services that were being reconfigured is the shortage of midwives. I think it's experienced across the country. Across the country, we actually, I think as of 2021, suspended the continuity of care midwife target for minoritized ethnic groups and women in the core 20, the most deprived groups, because access to midwives was insufficient to be able to achieve that. And yet, in the reconfiguration, we looked at the mitigation to shutting a very, very poorly used standalone midwife unit. I think it had an average of fewer than 30 births a year, was to expand access to home births, because that was a population group that was losing access to service. So the mitigation was to expand access to a service which is actually very, in terms of midwives, which is what they had a shortage of, is a very intensive user of midwives. And the response to the equity concern about that, because it's a very specific, quite privileged group that is able to make safe use of home births, the mitigation to that was actually that they would expand access to high-risk groups for home births, which is quite interesting in the light of recent coroner's reports around that. I've gone on a little bit. I've got some other stuff, some observations from the ICB, but I think I might bring that in later.
Yeah. Brilliant. Okay. Thank you. So I was reflecting on how you were coming back to the idea of often these decisions hinge upon changes to travel time and access, and that feels like a really quite simple way of thinking about something as an evaluator. From your experience, what sort of additional evidence is missing from having a more nuanced understanding of impact, and what role can we as evaluators play in providing better methods, providing better ways of generating evidence? Is it an evaluator problem, or is it a wider problem?
I think it's first of all a lack of clarity about what the outcome we're trying to achieve is. So is it, that there's multiple outcomes available. So it might be minimising inequalities in health outcomes. In health amenable to healthcare, for example, is although I struggled to articulate it, so maybe it's not a great example. So one is like a clarity about what is the goal we're trying to achieve, and then the lack of readily available data or even modelling on how you'd achieve that, or how the proposed changes or the decommissioning might affect that. I mean, in the reconfigurations we looked at, there's also kind of this problem about kind of where you stop looking, because usually the reconfiguration is just the thin end of, there's a much broader strategy underlying that. So, in the case of the maternity, there was a sort of maternity reform agenda, and it becomes. So the response usually from the Commissioner is, we're dealing with that elsewhere. So, which is, I think in healthcare, that's, I'm sure they were dealing with that. So it's quite difficult to kind of know what interventions are affecting what, I suppose, I think I'm saying.
Yeah. And so some of the interventions that you're talking about, having looked at in the past, some of them happened a number of years ago now, and reflecting back on the concerns that existed at that point in time about who was losing out on services, who was gaining in their place, did those concerns bear out? Do you have much of a feel for whether the concerns back then were necessarily the right call, or whether this was a general improvement for everyone?
I don't know the answer yet. I would like to do the follow-up. A lot of these things, they wouldn't have been implemented yet. I think the amount of lead-in for a major reconfiguration is pretty significant. We might have to wait some time.
Thank you. And so, again, one of the things when it came to planning this session was a feeling that there's not much in the published literature. If you do a PubMed search for published peer-reviewed articles about de-implementation, de-adoption, and decommissioning, there's not a great deal, but what there is some fantastic work that Leila and colleagues have done. And so I thought it'd be great to hear from your perspective of the work that you've been doing, particularly on de-implementation, but also as one of the leading academics on studying this, what your perspectives are more generally. And I think you've got some slides to take us through, Leila. So please take it away.
I do indeed. Thank you, Johnny. And I'm joined here by Will as well. And Will, did you want to introduce yourself? Will has joined at the last minute. Thank you, Will. But Will and I are both jointly work in this area. Will?
Hi, I'm Professor of Health Economics at the University of Bristol. So nice to be with you here.
Thank you, Will. We have prepared a few slides, like Johnny said. Please stop me if I go over, because I haven't timed them. I won't be able to see you, so please just shout out if I am.
Will do.
If I am just talking too much. Thank you. Right, let's see if we can share it. Okay, hopefully you can see that.
Yeah.
Can you see my screen? Yeah.
Yeah, we can now. Yeah.
Great. I'm not going to spend too much time on the introduction, but Will and I want to just present some of the work we've done in this area over the years. So we're based at the University of Bristol, and the work that we've been doing here in Bristol has been mainly focused around stopping doing things, but rather than redesigning services or pathways, we've had a particular interest in stopping particular healthcare interventions. We've done a little bit of work in antibiotic overuse, but over the years we've done more and more work around procedures, so stopping embedded procedures or reducing embedded procedures, in particular in the area of surgery. So the language in this area has evolved a lot over time. It's still variable. So 10 years ago we were talking a lot about disinvestment as a research team and in the wider literature. That had its own challenges because it can have strong financial connotations, and we'll come on to that in a second. But as this field has grown, terms like de-adoption and de-implementation are becoming a bit more commonplace. One reflection, I guess from an academic perspective, is trying to do any sort of syntheses of the literature in this area is quite tricky, partly because of this fragmented terminology, but it's also an issue of these topics span quite different fields, so from health economics and health policy to implementation science, increasingly evidence-based medicine and ethics, and they all speak different languages. So it is quite difficult to synthesize knowledge and understanding, which might have implications for evaluation actually. So building on that, this is, I think, related to what Sally was saying. There are different motives for why you might de-implement a procedure, and that adds to the complexity. So some will talk about, stopping something because it's harmful. Not many examples of that, but they do exist. You might stop something or reduce it based on obsolescence or something just being dated, so an outdated technology. Something might be ineffective, so there might be evidence that it just doesn't work. Or it gets a bit more tricky when you try to justify the implementation based on lack of evidence, which is a slightly different thing, or not enough evidence. Cost effectiveness, of course, is another potential driver. And slightly different to that, but related, is affordability. So something could be, cost effective, but simply not affordable or not a priority. And those are hugely different, motives, and that does have implications for evaluation in particular, but also what you do to actually reduce these practices. So going back a bit now, about 10, 15 years ago, there has been some kind of work looking at how do we do this in the NHS in relation to, at the ICB level, at the time it was primary care trust level. And the big picture kind of findings from this work was that there was a lack of kind of explicit process. There are more frameworks these days, but still very little guidance on how to actually de-implement or de-adopt. I'll just go back a second. One of the calls from commissioners around 10 years ago was for more central support with identifying areas for potential de-adoption. That call was answered partly in 2019 through the NHS England led evidence-based interventions programme. I won't go through all the objectives here now, but I'm very happy to share slides. But in brief, their ambition was to ensure patients only receive interventions for which there's an established high-quality evidence base. So they introduced 2 waves of interventions as candidates for de-adoption, was the term we were using then. I'll just show you some examples. So wave 1 had 17 surgical procedures, and they'd issued central guidance on either not doing these at all for 4 of the procedures, or more commonly doing the other 14 in carefully defined patient groups. So this was more about offering surgery if patients met a given threshold. Wave 2 grew in its list, and all I wanted to, sorry, probably can't read the slide, but wave 2 had the addition of slightly different kinds of procedures, which we'll come on to in a second, and they expanded the list to look at diagnostic tests as well. So Will and myself and the team did some work around evaluating this programme as our latest work in this area. So we aim to understand the delivery impact and the acceptability of this national programme. And we were hoping that we would be able to use those findings to generate recommendations for future efforts to de-implement in this area. So very briefly, the EBI programme appeared to have quite limited impact on procedure rates, and its ambitions to nationally reduce the volume of the procedures it targeted, and another one of its metrics was reducing geographic variation, which also didn't really seem to change for most of these procedures. There were some mixed findings for their wave 2 procedures, but it's quite difficult to interpret that data because COVID happened. So pretty much everything ground to a halt when list 2 was published. So it's quite difficult to distinguish what was COVID and what was COVID effects and what was this programme. We did identify that there were some signals of time to surgery being reduced for some patients, and increased use of GP or primary care-based interventions. So that would suggest perhaps some shift in where care is happening, but again, difficult to untangle that from COVID. We did look at ICB's policies to see did they actually adopt the EBI recommendations, and briefly, it was highly variable. So just under half of ICBs actually took up the EBI recommendations. So the question was why? So opening the black box to try and really understand what's going on. Oh, sorry, was that a question?
No. Carry on.
Sorry. So we, sorry, I'm probably talking way too fast. But we tried to understand, how this program was actually received on the ground from different stakeholders' perspectives across the country. So we did some qualitative work, just over 100 semi-structured interviews with different stakeholder groups, from commissioners around the country to surgeons from the specialties affected. There were 6 different specialties we honed in on, and patients who were, actually we interviewed them in secondary care settings because they had already been referred for these procedures. So we wanted to try and understand their care pathway. Briefly, commissioners very much welcomed EBI. This is, against the backdrop of historically being lone wolves when it came to healthcare prioritisation decisions, and in particular de-implementing. So EBI was initially perceived as, long-awaited help from central bodies to support with this quite difficult thing they have to do. And there was particular enthusiasm for potentially reducing the postcode lottery for some of these procedures. However, List 1 didn't quite meet these expectations, largely because commissioning bodies already had their own policies for the areas that EBI targeted. So they're often referred to as the usual suspects or the low-hanging fruit. This wouldn't have been a surprise, I don't think, to the EBI developers, because part of their rationale with starting with these procedures was that they felt it would be a bit easier to not go too fast too soon, so that if there was already a precedent or a history of thinking that perhaps these procedures are low value in some contexts, it would be easier to get stuck in with this and build on it from there. However, the challenge was that local policies, so commissioners' existing policies, were often more stringent than these national thresholds. Because they've been, developed independently, there's no kind of consistent central process for supporting how these policies had been developed. But the challenge was that they then couldn't afford to change their policies to meet the EBI thresholds. So as this commissioner here said, you can only spend your pound once, sadly. People say, well, they've got all these central-based views, but actually we still have to balance the books. So quite tricky for commissioning bodies who, had... Having said that, so one caveat, the EBI programme did specify that commissioning bodies were permitted to adopt more stringent thresholds if they felt that was for the best. But that was small print, not really very explicit in their public-facing documentation. EBI also created a lot of work for commissioners. So what we came to understand in a bit more detail was just how difficult putting these policies together is. So there's this history of negotiations with local clinicians, the public to an extent, but often commissioners would talk about, several months, sometimes years of meetings with clinicians to get the wording for their policies just right. So it wasn't just a case of, even if they could adopt EBI, could afford it, it wasn't a case of just changing their policy. They'd have to go back and try to work through their quite detailed stepwise way of reviewing and changing these policies. So not particularly easy. Just fast forward to wave 2 and 3, it's interesting to observe from a researcher perspective that the EBI program itself changed quite considerably. So So the biggest change was that it was no longer kind of explicitly about reducing activity. In fact, in some of the recommendations for ways 2 and 3 were about increasing activity and appropriate care. So it seems like the programme was shifting away from DEAD option. I think that's all I want to say on that point. Just a few more points about clinicians and their patients' perspectives. So clinicians had very little awareness of the EBI programme, but they did have a lot to say about these pre-existing commissioning policies. So clinicians broadly they were mindful of the policies, but I think that it's fair to say they did not feel that these policies actually influenced their decision-making or practices. They were more kind of framed as administrative requirements. So as this ENT surgeon says, filling out another bit of paperwork to confirm that patients meet the criteria. Importantly, clinicians were very explicit about being willing to practice outside the guidelines if needed. So obviously there may be times when your patient doesn't fit the criteria. That wouldn't stop me from doing what I think is needed. And this was a very kind of common sentiment. What we did find was that there was a lot of contention around how you frame the rationale for the implementation. So commissioners would, and actually in the commissioners and perhaps even the EBI programme itself would often frame efforts to stop or reduce activity as stopping unnecessary things or stopping low value care. And this was a real problem for engaging clinicians, because they tended to view effectiveness not in these quite black and white terms, but more it's more nuanced than that. So it's about which patients benefit and how you weigh out the potential for benefit against the risks and the other care that they've or other treatments they might have already tried. So it wasn't as simplistic as it doesn't work, stop doing it. So as you can see here from this slide, saying something is not evidence-based was far too blunt from from clinicians' perspectives. So again, this surgeon said, my problem is that some of the evidence just isn't great. Just because it's there, it doesn't mean it should form the basis of all the decisions we make. So quality of evidence was a big concern. From patients' perspectives, it's quite interesting. So we interviewed patients, about half actually went on to get surgery, have surgery, and half were not listed for surgery in secondary care. And this is currently in the process of being published, but we found that whether or not patients actually were listed for surgery didn't seem to have much influence on their satisfaction. What did influence their satisfaction was the process of care. So the timing of referral to secondary care, and there was some concern about potentially missing the boat because they'd spent too long from their perspectives in primary care. But more about the consistency of information and understanding why they were referred or weren't referred. Some became aware of these restrictive access policies, some didn't. Those that did become aware talked about receiving quite inconsistent information about thresholds over the course of their pathway. And basically it was the quality of the information provision that seemed to really shape their satisfaction with their care. So understanding why they were or were not, being referred at a given time point, rather than the end point of actually being listed for surgery or not. I'm almost there. So based on all of this information, we developed several draft recommendations based on this evidence, which we took forward to a co-production workshop with commissioners, surgeons, public representatives from around the country. It's actually really a fun event. This just captures some of the discussions. Sorry, I really am whizzing through these slides, but just to cut to the end points, the final recommendations arising from this work can be, they fit into different blogs or clusters, if you like. So there were Lots of recommendations relating to communication with patients and the public. So more about more public communications to normalise de-implementation. A separate issue is how to actually discuss restrictive access policies or efforts to de-implement with patients at the point of care, and the importance of consistent messaging across their care pathway. Again, I think this links to what Sally was saying. Several uncertainties and concerns also arose around how you can safeguard the doctor-patient relationship and trust in the NHS, and also, importantly, what the implications are for equity of access to care. So these weren't necessarily procedures that don't ever work. It was more a question of who are they most appropriate for. But there was real concern that we might be inadvertently restricting access for those who could benefit. There were recommendations related to involving health and care professionals throughout the de-implementation process. In particular, interpreting evidence through a clinical expert lens, and accounting for multidisciplinary involvement in the implementation decisions about surgery. So often we felt we were a little bit blind as to the true kind of complexities of how a patient had arrived at where they'd arrived at, because primary care was not part of our study that was funded, but we were hoping to look more into this in the future. There were some cross-cutting principles, and so the importance of being transparent around the rationale for de-adoption, going back to that slide I presented at the beginning, especially if the rationale is based on resource constraints, i.e. the need to prioritise, rather than something, for example, being harmful or not effective. Real concerns, as I mentioned, about implications for health equity, and how you're going to address persisting need. So if somebody, for example, might not be listed for surgery because surgery is not appropriate or evidence-based, well, how are you going to then make sure you're still addressing their symptoms? So there needs to be alternatives in place. Adopting a whole pathway approach, as I mentioned earlier, and a strong need for nationally consistent guidance and principles to work from to make these de-implementation decisions. Even if the decisions you make locally are different, there was an appetite for at least having some consistent principles. I think I'll stop there because I've talked too much. So
No, at all.
happy to.
Thank you so much for that, Leila. That was a really, really helpful presentation. I think just to understand from the sheer wealth of qualitative information that you've collected over a lot of interviews with different stakeholders, it gives a real deep understanding of perspectives on doing less of something or not doing something, which I feel like, at least from my understanding of things, has been quite lacking in the past. So I think it's tremendously valuable work. I was most interested, I think, in how you talked about the idea of needing to normalise de-implementation from the perspective of patients and the public. And is that something that you've seen good examples of happening successful, or is this more an aspiration to do it better?
I personally think it's still an aspiration, but we can do better. I don't think it's a difficult thing to start working towards. We, as a research team, sorry, I haven't presented it today, but we have done a little bit of work looking at trying to understand what different restrictive access policies look like around the country, depending on where you live, what ICB you're situated within. And we struggle to locate those policies. Like, it's so difficult to find them on ICB's websites. It's not ICB's fault, of course. It's just there is no, as I mentioned, it's not normalised. There is no consistent, guidance or support for how to put this in the public domain. They do exist, and they are transparent, but quite varied. Commissioners that we have spoken to are still talking about, the difficulties of being perceived to ration care. Essentially, prioritisation is their job. You have to do it, but there is still very, I think, little central normalisation of that concept. So the EBI programme was very much framed around evidence-based care, stopping things that don't work. It didn't, I don't think, well, from memory, it didn't really talk about those more contentious, how do you prioritise, what's affordable. Essentially, some people might not get the best possible healthcare or outcomes. That absolutely wasn't there, I don't think. So that's my impression, that I think we've got some way to go to
Thank you.
talking about those issues. Yeah.
Thank you. I realise that I've not prepared either of you for this, but I just wondered if, I saw you both taking some notes, whether you had any immediate reflections on what Layla's talked about in terms of the evidence that she and her colleagues have generated. On Sally.
Thank you. I've heard Will's version of this as well, which I was really excited when we first started doing. So it was earlier this year, Nuffield Trust. My colleagues looked at this ICB's £300 million saving reduction, and in that, one part of their plan was they were going to make a chunk of savings at EBI that originally I thought we would look at, because it would be a very interesting case study. Who is actually losing access, who isn't. But it turned out that of the £300 million saving plan, EBI totaled 1 million. Right, and I very much agree with Layla's point that actually, when it comes to the benchmark, because all this stuff is now available on NHS Futures, whatever that platform's called, ICBs can look up to see where they're sitting on the EBI thresholds, and I think this particular ICB only had 2 areas of the EBI programme where it was above the threshold for the population rates of those procedures, right? So when I say £1 million of reduction, that might sound like a lot to people, but to compare it to, they were going to make 24 million by reducing elective procedures in the independent sector, for example. Yeah, so it was an absolute fraction, and around about 15 million. Rowan might remember because he edited it for me, much more through reducing prescribing. So yeah, that's I think that that it's probably, I get the impression it's quite limited in terms of the opportunity. Layla, you said it's quite hard to find the schemes. Before I worked at Nuffield Trust, I used to be a journalist, and this was kind of bread and butter to journalists, obviously rationing, postcode lotteries, and I think one of the reasons why they do, I think actually they exist, but they just keep being renamed. So I remember the first one was the Croydon list in the mid-2000s, looking at people a little my age, and then procedures local and core value. So they keep being rebranded because they're controversial. But one of the things that really interests me is the idea that, well, one of the pushes behind this is to create headroom for innovation. I think we're now at this very sticky point where some of these procedures of low clinical value or evidence-based interventions actually may have a cost per quality that is below the NICE threshold. So just to kind of, we're talking about that quite a lot at the moment with Nuffield Trust, but I know, for instance, that the ICB that we looked at, it actually had gone through and tried to calculate cost per quality of the interventions that it was introducing these restricted criteria around, and their cut-off point was 20 to 30k, and now, which is kind of a very interesting kind of problem that I think commissioners are now going to have to deal with, how you have those conversations about saying this is not a cost-effective intervention, but if it was a new pharmaceutical, then we would be funding it.
Thank you. Anna, I don't know if you have any reflections.
Yeah, I guess what struck me is really, which is when I started writing, is to really think about how we communicate with the public about these things. And I think that the fact that it's difficult to get a commissioner to come and talk to us about this, the fact that you talk about having to rebrand the name of lists because they're not very popular. So it's coming through in a lot of the conversations, all the language you use. So I think, if there was a world where we could actually have these discussions more openly and sort of really engage members of the public in deciding, what is their need, what are the services that we want to continue to offer, and where can we scale things down. I think that would really be a game changer. like Leila said, it's difficult to know an area where that has been done well. I think one area that came to mind, and I think some people in the room, including Stefano, might know, the very first evaluation that the Improvement Analytics Unit ever undertook was the reorganisation of A&E services in Northumberland. So this is well over 10 years ago, and now accidentally live in that same affected area after having left the Health Foundation. So they essentially built a new emergency specialist care hospital and closed down 3 existing A&E sites on what is geographically quite a large area. And certainly at the time, and I don't think we paid enough attention to that because we're sort of a bunch of qual nerds, that there has been a really good sort of level of engagement with members of the public locally, and it was considered to be quite an acceptable move. But I think really important for them, it wasn't the closing down of 2 and keeping 1 open. It was building a new site in a new location, so everybody lost what they previously had, and everybody had to go somewhere else. And even though that new hospital is not that far from one of the existing sites, I think if they had to try to just close 2 A&Es and that's it, that would have been a very different conversation. But maybe there is something to be done to actually go back and engage with people in that community now to try and understand how they look back on this sort of 10 years from now. I think what is very ironic is that literally one of the first interactions I had with a neighbour when I moved into what is a very rural part of Northumberland, it's like, oh, by the way, if you ever need to go to hospital, don't bother ringing an ambulance because they'll drive you all the way out to Cramlington. Just knock on my door and I'll drive you to Newcastle, which is quite interesting. So, but I think there are examples out there, and maybe we need to think about how we learn from those.
Thank you. So I'm conscious, firstly, of time, but also secondly that we've been doing quite a lot of talking, and I know you're a room full of experts with plenty of experience yourselves, and I think I've got a list of questions that we could go through, but I wanted to just gauge in the room whether there are any questions that you had, and maybe we could make this into a little bit more of a conversation where you perhaps would be willing to share some of the experiences that you've had, either as those working in the context of doing less of something or evaluating the impact of that. From a microphone's perspective, is it, just looking at my colleague over there, is it best if we do a roving mic from one of these and take them round? I might do that in that case. In which case, do we have a show of hands? Is anyone willing to ask a question? Oh, just trying to pull this out. So I think it's Andy, is it?
Yeah. Thanks very much. I'm interested in whether there's either evidence, so it was interesting your talk later about the conversations with surgeons, but whether there's insight more broadly from the panel about the role of like culture and almost incentives. So I've heard it said by, I think it was a consultant at a different conference, a consultant will be hauled in for the things they didn't do, but they're rarely called in for the things they did do. So there's almost an assumption of, if in doubt, do more, and that may be sitting behind some of the decision making, not from commissioners, but from those delivering care. And some of the comments in your work later were interesting on that point about sort of, it felt like almost a bit of gaming the system to get people into the criteria rather than trying to be more objective. And that's not a criticism, it's just the culture and the incentives and how they affect behaviour.
Thank you. I don't know, Leila, do you want to make a start with that one?
Yeah, it's thank you. No, it's a good question. I think so from surgeons' perspectives, they were driven by the patient in front of them, and they truly believe, based on their interpretation of the evidence, that the patient would benefit, from a given procedure. We did explore with surgeons like how they say no. Do they find it easy to say no? Are they increasingly saying no? And it's interesting, like comparing it to 10 years ago, saying no does seem to be more of it's not as alien a concept, I don't think, for at least the surgeons we interviewed in the last project. They were very comfortable with saying, I don't think it's the right time, or using different strategies to support with that, like I've forgotten what the name for it is, but you can do a PIFC, so patient-initiated follow-up, where patients, would be able to almost circumvent primary care and come straight back to secondary care if they're still having symptoms, for example. So I think it's changing. Surgeons aren't necessarily this, we always want to intervene kind of a specialty anymore. But yeah, going back to the question of incentives, there was some, I don't know if this would be a disincentive, but surgeons would often talk about how, doing no harm is actually part of it's baked into their decision-making processes. Like they're taught that in medical school. They have concerns about, from a medical legal perspective, having to potentially justify, a particular decision if an operation goes wrong, or if the risks do outweigh the benefits. So it very much, at least from the interviews, seemed to be something that they're grappling with all the time. Their view was that these policies were in place essentially to save money. That was the reason why they had no problems with just taking the box or finding a way around the policy. Sorry, it's complicated. I don't know if I've answered the question.
Thank you.
Yeah, I guess I wanted to comment on the point of culture. I think risk is sort of a really important part, and it's very much part of culture, I think, and it's been mentioned a few times, and I made some notes on this before as well. So I think the risk appetite, sort of the willingness to accept risk when you introduce a new intervention, I think is much higher than the willingness to accept risk when you stop doing something. So I think, we're all aware of unintended consequences, and if we introduce something, we don't want to exacerbate inequalities, and we put sort of measures in place, but inherently we're probably okay if like some of that goes a bit wrong, and we'll think about sort of course correcting it. I've got an example in our trust where we try to introduce protected sleep, or we have introduced protected sleep for our inpatients. So it is standard practice in mental health settings for inpatients to have observations once every hour throughout the night, and for elderly patients sometimes every 30 minutes, which is very disruptive to their sleep, as you can imagine, because it involves as a minimum sort of doors opening and closing, and light from the hallway coming in, etc. So we piloted something back in I think it was 2017 when it was first piloted, around offering protected sleep between midnight and 6. So for 6 hours, people wouldn't undergo any observations if they were deemed not at risk of self-harm, essentially. It's taken about 10 years to spread that across the trust, because mainly the perception of risk. So if you think about the early evaluation work that happened within the trust, it was all about measuring the number of serious incidents, measuring the number of deaths, measuring incidences of self-harm, and there was no analysis into actually the benefit to patient. So qual work sort of suggested that patients preferred it, staff preferred it, but individual ward managers and group directors would have to okay on a single ward to do this, and it's just the culture of risk and risk aversion that sort of stopped that from spreading. And it's now 10 years on that I'm leading a piece of evaluation where we're looking at the length of stay, because everybody's saying, oh, patients recover faster. And it's like, why did we not look at this 4 years ago to sort of be part of that discussion? And I think that's just where, and I appreciate it sort of, I'm selling something as a new initiative, as stopping something, but I guess the idea was let's do less of something. So yeah, I think culture in that sense it plays a very important role.
Sally, did you?
Yeah, I'm just really struck by Layla's comment that surgeons were saying that they think they did have the tools to say no to patients, and that's really interesting about how PIFU is perhaps facilitating that. But also come back to this idea, if it's just about saving money, then we're not signed up for it. And something is really, so back to your question about culture, something culturally is really, we've really failed if you say, so of course the health system has to save money in the sense that the health system does have a limited set of resources. Yeah, we don't put pound sizes on it. It's the limited set of resources is the professionals that are working in it today and this week. And yeah, it goes back to this lack of a just even a vocabulary for talking about how those resources are prioritised, how you prioritise the patient in front of you now compared to the patient that hasn't got in front of you because you're spending this amount of time with that patient, so I think what clinicians are meaning when they're saying if it's just about saving money, then I'm not signed up for it, is any sort the rationale around prioritisation isn't getting through. If it's just like there's been no consideration here whatsoever, we're just not doing grommets, rather than having a conversation about the benefits that on a population level that might be extracted from that procedure.
Thank you. So, Alison, I handed you the microphone. Did you have a question?
I did, yes, but
Perfect.
if you want to come back on any of that, I'm happy to
As you want
pause.
to.
No, go for it.
So I'm Alison. I work on the Health Foundation's NHS Productivity Commission, and I'm interested in the discussion about the balance between what should be done nationally and locally. And I was particularly struck in your presentation, Layla, around some of the findings about the EBI programme. I assume that NHS England commissioned the Academy of Medical Royal Colleges to lead it, was that so it would have the kind of status and credibility of being clinically led. And I should say I used to work at the Academy of Medical Royal Colleges, but not on the EBI programme. But I was interested in the findings that that kind of status of being clinically led didn't cut through to engagement with clinicians on the ground. And I feel like it's often an easy recommendation or conclusion to make that, these things should be clinically led. But I guess I'm just interested in maybe probing a bit further about what does clinically led or what does clinical engagement mean in practice, and how does that happen, at what level and with who? That's obviously a huge question, but if anybody has any reflections on that, I'd be really interested. Thanks.
Thank you. I don't know, Lila, do you want to have a first go at that because it was directed at you initially?
Yeah. Another good question. I haven't presented the detail around this, but it was interesting. So that the EBI programme, it was NHS England led fronting for that first wave, which is where a lot of our findings came from. They absolutely, and I think it was Amanda, as you said, shifted to the Academy of Medical Royal Colleges being the public-facing lead when it came to List 2 and 3. And that coincided with this shift in the programme towards appropriate care and some recommendations to increase activity. I took it out of my slides in the interest of time, but another issue was that a lot of the procedures in List 2 and 3 weren't measurable anymore. They weren't things that commissioners could count and ascribe, money to. So the programme changed considerably. I think it would be interesting to know if it did have that Academy of Medical Royal Colleges fronting from the very beginning, would it have been different? I don't know, but absolutely, if you look across the literature, it is, as you say, all about you clinicians absolutely need to lead this. It needs to come from within their specialties. So it's not just about interpreting the evidence to generate the recommendations, but also identifying areas for potential de-implementation in the first place. So I think that the Choosing Wisely programme, it's an international programme, did exactly that. But again, the evaluations are showing very little impact for Choosing Wisely too. So it's still a lot of uncertainty.
Yeah, thanks. Give me an excuse to talk about another bit of the ICB programme that we looked at recently. So a chunk of decommissioning seems to be related to stuff that is no longer defined as a healthcare intervention. So we haven't talked about it today, but in the ICB we looked at, a great chunk of savings were actually over-the-counter medicines, medicine optimisation programme. A bunch of that would be kind of antibiotic prescribing, but a significant amount was also reducing over-the-counter prescribing, and this sort of leads back to this question of what is healthcare. And as far as we could gather when looking at this particular ICB, the definition of healthcare is fairly tautologous. Healthcare is what clinicians provide, right? And so we have this, what clinicians provide, we have kind of two things happening at the same time. We've got this constant expansion. We've got expanding diagnostic criteria. Mental health in neurodiversity is a really good example of that. So now clinicians do things that they couldn't previously do before and that now are seen as kind of relevant things for medical or clinical intervention. So it's expanding there, and that's one of the reasons why we need to free up cost elsewhere. And then there's another bunch of stuff that clinicians used to do, like years ago prescribe paracetamol, or that now they don't do, and the message is, well, the NHS should now stop spending the money on that. And because this is available over the counter, or vitamins was another quite a large savings area for this particular ICB. And then separately in personal health budgets, so typically for severely disabled adults, very significant savings were being made by reviewing personal health budgets that might have been set up under a slightly more generous period in NHS funding, and removing from that any form of expenditure that again didn't look clinical. So what that was effectively removing things like, which was called socialisation. So things that I remember when I was a journalist in the 2000s, when these things came in, there was great enthusiasm for using personal health budgets to help people live as fulfilling a life and as normal a life as possible. Well, these are things that are not being delivered by clinicians, so therefore we're saying this is not healthcare intervention, this is no longer a legitimate use of the NHS budget. In answer to the question was, what should be done by clinicians and what should be done centrally, what should be done locally? Where those decisions, that this is no longer a legitimate use of the healthcare budget, I'm not, by the way, saying I agree with that, I'm saying this is what is actually happening. If clinicians are stopping doing these things, but clearly there's a healthcare benefit from taking paracetamol, as far as last time I heard, it's still being advised for various symptoms, reducing temperatures, etc. This is still in some senses a health intervention. Then some agency needs to be paying attention to how else that is happening. So one of the reasons we do not see over-the-counter prescribing reduce as much as NHS England might like it to see reduced is because GP practices in poor areas don't do it because they are worried, for good reasons, about the impact on deprived patients. But those kind of national decommissioning decisions don't seem to be made in tandem with any sort of a deep consideration of, is the benefit system keeping up with are we creating problem elsewhere? Are we ensuring that we're providing people with the means to keep up with these things that the NHS is stopping doing?
Thank you. Arne, did you want to come in on?
I think the only thing I'll say is that I think in this context, and whether it's clinically net or not, or whether it's sort of, I think that the principles of good implementation would apply to good de-implementation as well. And I think if somebody centrally says, oh, by the way, you're now doing this, like that nobody's going to listen. Clinicians will be the last to listen, I imagine. But I think, so for any of this to work, I think you need that level of engagement. You need to have the relevant stakeholders sit around the table, and something shouldn't necessarily be clinically net. Everyone needs to be involved, including clinicians, on those types of decisions, but probably also patients and also other stakeholders that form part of that. But I think that's, in a way, brings it back to we need to be able to talk about these things point, because as long as we can't talk about it, it's mainly going to be lists produced somewhere by someone and then shared for consideration elsewhere and not taken up in the same way that we really struggle to adopt and spread the good things as well. Yeah.
Thank you. I think we've got time for one last question, if anyone has got a burning question they'd like to ask, please.
Hi, I'm Jenny. I'm from Rand Europe. It's more an observation, but I'm interested in your reflections. We've done some work looking at de-implementation of paediatric early warning scores, local ones, and then straight on the back of that, they re-implement a national paediatric early warning score, in case we haven't got enough terminology in the room at the moment. But it's interesting, we interviewed a range of staff, primarily nurses, and actually there was less opposition, and sort of they talked about fatigue change and another change and that, but actually they were quite on board with, we're taking this away because this new thing is better, perceived to be better, perceived to be more equitable and safer for patients. So I guess my reflection would be that I hadn't really thought about it before, but perhaps what follows and the sort of education around why you're getting rid of something and if something's in its place might actually be an important factor to staff acceptance of these things.
Great point. Anyone want to come in?
No, I agree.
Yeah. But I guess in that case, there's what is being replaced, what is new is quite similar to what was there before in terms of the scope of what it does. And do you think sort of like that more direct replacing, not quite like for like, but similar for similar, makes it a much easier explanation?
I think it makes it easier to get on board with change, but it can make it quite cognitively difficult to go from a form to another form that looks slightly similar but is very different, especially if you've had many years of being told the first form is really important. So there's other challenges, but I think it's something I hadn't reflected upon until this session, so thought I'd share.
Thank you. Thank you.
Can I ask the audience a question?
Go ahead.
Because this is about evaluation, right? And I think we've sort of spoken about a lot of the challenge to do with the implementation. What, as evaluators, do you think your role is in supporting making some of these de-implementation decisions? So what can an evaluator do to help us in the trust or other healthcare organizations decide what to stop doing? Because I think that's the crucial bit where, like, you can't just stop something, see how it goes, and then we'll just put it back, right? So it's sort of how do you use the data and evidence, and maybe it's more rapid analysis and rapid evaluation, but how can you make a reasonable prediction of what will happen when you stop something? Any thoughts? There's a mic next to you.
Hi, Drew Shard, NHS England. I think the piece I'm gathering from this that we can really help with is the implications. So you can have good evidence on paracetamol, and things along those lines. I worked a lot on IVF and around that. Good evidence, but the implications of what the downstream of we're going to restrict that, we have to say restrict or decommission it, would actually mean. I think that's where a lot of this evidence on what I'm hearing here is not there and that's what a lot of the clinicians, it sounds like it's them to process themselves, is the risks of not doing that. And also, but what we really don't understand is what the service users' patient implications of that are. And I have to go back to the IVF work, and they were, tourism and the implications of that in terms of what that meant. So I think from an evaluation perspective, it is that, I suppose it's the social side of the technical bit, if you want to go down that road. So I think we can help in that space is where I see it.
Hi, I work for a GP Federation in research, and I'm also a Knowledge Mobilisation Fellow for North West London ARC, or previously ARC. And I think from a primary care perspective, it's really challenging because the way that primary care is commissioned in terms of contracts and QOF, that even when you evaluate something that's not particularly working, there's block contracts involved, and so it's not as simple as saying we've evaluated this piece and this is the evidence that actually we could be doing it differently. I think it's part of just a wider system of politics and processes, as you said, that actually make change really complex. In terms of the adoption of new information or the way we do things, a lot of it is around digital, but we know that actually excludes a large population of the communities we try to engage with and the health inequalities we're trying to minimise. So I don't know, I think that's obviously a really big response, but I think it's just the system we're navigating is really complex, and we need to be more agile, I think.
Thank you. You just hold on to it. Thank you. So with that, I'd like you to show your appreciation for our panellists, and thank you very much for joining us. And enjoy your lunch when it comes, which is very soon.